Good afternoon, everyone. Thank you for joining us for today's session titled The Value of the Patient Balance Management Program. My name is Melissa Zuro with the Civista marketing team, and I'll be moderating today's session. Our presenters today are Amy Newson and Olivia Curran-Britt, Senior Directors of Revenue Cycle at Civista. Amy has in-depth knowledge of eligibility requirements at both state and federal levels, and extensive experience in providing access to care to healthcare providers' most vulnerable community members. And Olivia has strong service delivery experience and knowledge in developing and improving processes, procedures, and operational goals. Before I hand off the mic, I have just a couple housekeeping notes. If you have any questions during the session, you can submit them via the Q&A feature located at the bottom of the Zoom screen. Your questions will be addressed during the Q&A at the end. Also, we love being able to interact with our attendees, so we have an exciting way to engage with you during this presentation. There will be polling questions throughout that you can respond to. The instructions will appear on each slide, and you can either go to the website address or text your responses, and you'll be able to see the answers right on the screen. Finally, this webinar will be recorded and made available to you for future viewing. Thank you again, and now I'm going to pass it over.
Good afternoon. What is the value of patient balance management? 40% of patients said their interactions with hospital billing influenced whether they would recommend the hospital to a friend. Now is the time to streamline the patient billing experience. We have to align the healthcare revenue cycle with patient experience. Providing a high-quality patient billing experience around a clinical encounter has become not only important for patient satisfaction, but also the bottom line. Patients with negative billing experience are 5 times more likely to complain about the experience to another patient. So what we're hearing now, basically the top 5 patient complaints is 1, long wait times. They don't want to wait on a phone to speak with someone. They don't want to wait a long time to see their doctor. Number 2 is issues with staff members. Whether that's someone in customer service, at check-in, a nurse, that is a number 2 complaint. Number 3, of course, is the amount of time spent with their doctor. They want to spend more time with that doctor. Number 4 is insurance and billing. Health insurance, of course, can be tricky to navigate for both patients and providers. They're faced with higher copays, more bills than they anticipated, and sometimes it's hard to reach the customer service department. And number 5 is lack of communication and dismissiveness. So with so many patients coming in and out of doctors' offices and hospitals daily, the occasional complaint is nearly impossible to avoid. However, the way a healthcare institution handles those complaints can make all the difference in whether a patient returns in the future. So quick follow-up, open communication, and long-term improvement by really listening to customer feedback can really help healthcare organizations achieve greater success and really show their customers and their patients that their voices matter. So we have to address the patient experience and consumerism. So today's patients are acting as consumers. Patients conduct the necessary research to choose providers that represent the best value in cost, but also in that care quality. So what exactly does consumerism in healthcare look like? And how can doctors and providers navigate the new healthcare landscape? So consumerism is the movement in which patients are conducting research and making decisions in regard to their healthcare. They are no longer relying on their physicians and insurance providers to tell them who to see, where to obtain care. And as deductibles have gone up and patients are responsible for more of the cost of their own care and is coming out of their pocket, they want the best value. Patients now want to know what the costs are associated. They want to understand the patient satisfaction rates. Patients also take into account the physician experience with the type of condition they're dealing with. So they want to understand the history of complications or mistakes. This really helps the patients decide who to trust with their care, because it's really where do they want to spend their money.
So I want to talk about, current processes today. And in healthcare industry, we are presented with an array of confusing choices, contact points, service flows without a lot of upfront information. And barriers, really do include lack of information around the cost and options for managing medical expenses. Currently, disparate vendors manage multiple parts of that patient experience. So in this example, it shows that a patient is dealing with various vendors regarding their bills, from working with a PFS department, eligibility department, financial clearance center. There's bills that are with self-pay, there's bills that are with bad debt, and this patient may have different representatives that they have to work with each of those departments. So in this particular example, let's say that a self-pay vendor leaves a message for the patient to pay on, visit or bill for, and they don't know that, the patient has, several other visits that are outstanding, and they forget to leave a callback number. Then the patient calls the PFS vendor who's managing bill one, and they pay $400 on bill one. So then the bad debt vendor calls to make a payment, to have the patient make a payment, and the patient is calling back and they're saying to the bad debt vendor, well, I've already made a payment, and now the self-pay vendor is sending a patient a statement for that bill for. So it just causes a lot of confusion and frustration. And depending on your vendor partnerships or internal departments, that patient can be dealing with multiple places and people to go to regarding various bills in that revenue cycle process. So they have various points of contacts, different bills and statements that they're receiving, multiple incoming and outgoing calls, and there's a lot of handoff on swivel chair movement between those departments or vendors. So a patient shouldn't have to talk to 5 different people to get their questions answered. So what if they could talk to one person to get all of their questions answered as it relates to their open balances, and just engaging in that strategic outreach to ensure that the patients understand, what and why they owe something. It really does result in higher probability of payment, and customer service and that consumer experience is key here.
So now we're going to have a poll. If you haven't had the opportunity yet to open a web browser on your phone, go ahead and agree to the cookie policy and then click skip. So what would you change in the patient responsibility process? Think of yourself as a patient. What would you change? How could interactions be better? What's important to you? Okay, it doesn't look like we have any responses, Melissa. If we want to go ahead and continue, it looked like there may have been one.
Explaining.
Yes, explaining.
Was that explaining beginning? Oh,
silos.
Clear
Yes.
process, explanation from the beginning. Yep, absolutely.
Yes, those are all great. It's really complex for them to understand what they owe, especially if there's lab work, if there's additional bills going out, they don't understand where they're all coming from. And it can be very confusing, and many don't even understand how to read their explanation of benefits to compare that against the bill that they're receiving.
Absolutely. And understanding exactly what they owe and where does the, their responsibility go to, which physician, which service, which department. Definitely would be a change that needs to occur for more synergy. All right. So we'll, for the next slide, as a service delivery organization, we want to be able to give the patients a really great experience through their balance journey. And this also helps to move towards that consumer-based model approach as a result of increased access to information and enhanced consumer experience that we see in other industries today. So, coupling this with the rises in healthcare costs, that patients are now responsible for, it's really important to have a really good customer service and consumer experience for that patient. Recent studies show that patient responsibility is the third largest payer. And so, we want to be able to ensure that we're creating that engagement with that patient and really treating them as a consumer like we do, with like other industries do today. Just as an example of consumerism too, that I wanted to share was, last year I was planning a trip to go to Tahoe with my family. And this was our first vacation after the pandemic. It had us on lockdown for so long. We were going stir crazy. And I was planning this really large trip for a family of 6, which ended up becoming like a family of 11 because everyone wanted to come. And so with that large group of people, I really needed to have the best experience, but at lower cost, making sure it was cost effective. So, I looked up our best friend Google, right? Because that's where we start. And I was researching all the different places that I needed to look at, like what is the best rental home I could get. I wanted to look at all the events I could do, with skiing, with kayaking and parasailing and jet skiing. And so there was different options. I could go to a place on one side of the lake to do first come, first serve, and it was a cheaper option, but I may not get in. There was another place where I could book in advance. It was a little more expensive, and I could secure my spot with my family. So, I was able, after all this research, to really identify and tailor to the experience that I wanted to create with my family, right? So, when we think about that consumerism, we really want to be able to provide that quality service and giving that patient the best experience. And, it may come with more, there might be more, cost and whatnot in terms of, in terms of the service, but you're getting that quality. So when we think of a consolidated team with visibility into a full patient balance, it really does allow for that greater collection and application of payments. So the vision is to be able to bring the disparate vendors and services together, like bringing those services together when working with that patient, so they know how much they owe in totality with the provider that they had the care with. Patient balance management, it's really people and process and data driven. It brings synergy to operations. It streamlines and simplifies that experience. It integrates financial services of financial clearance, eligibility enrollment services, early out, and bad debt, and being able to handle those balances holistically. So we want to be able to look at decreasing that cost to collect, simplifying those services, improving the experience, shortening that self-pay cycle, and really decreasing the risk of the account cycling to bad debt. And it really does help increase that visibility to data, performance, and compliance. So by using a consolidated team, giving visibility into the full balances, it really allows providers and patients to make better decisions by creating that partner relationship. So you essentially have one throat to choke, right? So you have, so that internal and current staff can actually focus on other areas of the revenue cycle that may need attention.
Amy, I would add one other thing. Unfortunately, our patients and your patients don't always engage early. They wait until they get a notice from collections. But imagine that person being able to speak to someone in debt collection, say, hey, this got past me. I didn't address it, but I really need, I feel like I need some assistance. That rep could screen them there. That rep, or if they wanted to take a payment agreement, set up a payment plan, and they saw that there were new accounts that still had balances due, that debt collector could actually say, I'm going to go ahead and pull this out of bad debt for you, and I'm going to combine this with all of your agreements and let you make that one payment. So it's really about helping that patient resolve that balance, no matter what the age is, without having all these different letters, all these different phone numbers, all these different people to talk to. You shouldn't have to be transferred around to get help with financial assistance or set up a payment agreement. And if you've got multiple vendors and you've got children that don't have the same last name as you do, navigating that is very aggravating for patients that really just want to address the bill, even if it's not until it's an aged account.
Yeah. All right, so we go to the next slide. So the goal is to have a cohesive strategy for patient balance management and a cross-functional team, right, that has that visibility into that full patient balance journey. So it needs to be process-driven and support all of the patient balances when working with that patient. The patient can have, one touch point with a patient balance management team, as well as having consolidated statements that can include addressing that patient balance holistically from the patient's point of entry and working with the patient regarding working with their balance for assistance, determining eligibility with various programs that can cover their data service, setting up payment arrangements or payment agreements and plans, having one point of contact to work with regarding outstanding balances, and just having patient-centric approach. This workflow is just really showing everything from soup to nuts, right? From a scheduled, non-scheduled account workflow that goes all the way through to bad debt. So here you have the 2 points of entry for the patient. You have that scheduled patient, where you start with financial clearance and patient advocacy process. And this really can be done in a virtual environment, but they're checking for ID, verification, address verification. They're checking eligibility and benefits and obtaining authorizations and ABN if applicable. They're generating those estimates for the patient and providing education to the patient regarding their liability. And they're also attempting to collect, to do the pre-collection. And so a lot of these functions as well can also have no contact account functions, can be processed through, RPA and global resources, which does allow domestic colleagues to really financially clear the work and really help having direct patient contact. And then you have the non-scheduled patient. And this patient goes through the process of checking in where their remaining balance could be obtained, or there needs to be an eligibility financial screening that takes place for those patients that have an unplanned visit. And so the patient is treated clinically, and they can be admitted and seen by either financial counselor or an eligibility specialist or team member, especially for those high touch patients, those inpatients that really need that in-person review. And then they can also be seen virtually as well, with modalities of using virtual screening or telescreening options. And so being able to connect with that patient and also leveraging, applications such as electronic screening tools, leveraging electronic screening, electronic signature. So just being able to support that patient with that process. Patients are discharged and then they move over, those accounts move over to an eligibility self-pay follow-up team. And that's where that team continues to scrub the accounts. They look for correct address information. They're scrubbing for eligibility verification. They're really resolving that patient's balance and service dates. They can be looking for identifying if that patient is deceased or they need to file a claim on the estate. Or if the account does go to bad debt, they can scrub for bankruptcy and really just streamlining and personalizing that workflow for collection opportunity. And then all of this would have reconciled inventory, utilizing, one vendor. It's really easy. It ensures that the information is reconciled between where that account is in the revenue cycle, and it still continues to give that patient the great experience. The one thing I wanted to mention here is that patient balance management can actually start from any toll gate. It doesn't have to just start from the front end with financial clearance. It could, in fact, we have a partnership right now where we pursue patient balance management from the toll gate of early out. And the reason is that there is state regulatory rules that we have to comply with that doesn't allow for us to pursue patient balance management from the front space without being in, you have to be in person in order to do that with every patient, regardless of the what service they have. So we were able to create a whole process and workflow to be able to pursue patient balance management from the toll gate of early out. So this really helps with that, eliminating multiple vendors and handoffs and streamlining that consolidated communication, just to be able to secure, that payment and collection.
So our objective for a patient-centric patient balance management program, we want to drive that high patient satisfaction. We want to reduce inbound calls. So we want to map reasons for inbound calls to front-end processes. So did insurance not get entered accurately? Did we not get correct demographic information? Was something entered that was an immediate catch? We've had, sometimes the facility address was added as the patient's address, or the patient was loaded as a straight self-pay patient when they actually had insurance. So really looking at those reasons that we're getting those calls and looking at ways that we can improve. Also, if we're seeing higher point of service payments here and we're struggling in this area, those root causes can be mapped back, and we can look at ways to improve and get that cash in the door easier. And sometimes that's just doing some things as having, documentation up front around, insurance terminology, educating that patient, really explaining why they owe. They don't understand how much out of pocket they have. They may know their deductible, but they don't know that they have this much out of pocket. Maybe they qualify, maybe they only have Medicare, but they could qualify for Medicaid, and maybe we can help them get that coverage at that point instead of letting the account go on through the revenue cycle. We want to resolve those patient calls quickly. So we want to measure our abandonment rate and our talk time. We are going to have patients that are just going to want to talk to us for a long period of time, and we want to make sure that we're listening and we're satisfying that patient. But really, how we resolve those accounts and how we prevent additional calls coming back in is very important. Did we resolve it the first time around? Did we fully close the loop? Did we take the correct action? That is how you're going to drive high patient satisfaction. You do not want them to have to call you back. You want it one and done, and it to be a high quality experience. And then we want to reduce the non-clinical touch points. So minimize the number of people that are contacting patients from different processes within the revenue cycle. We really want to measure the contact instances that we have against the number of contacts and the registrations. So these are our tactical solutions. So really what we're wanting to do with this process is we want to make it consistent. We don't want it broken. We want it to have a state of stability, no disruption for that patient. So our approach is a delicate balance of reducing bad debt and managing the patient financial experience. So currently, about 40% of Americans struggle to meet an unplanned expense of just $400. When we went through our first kind of recession, when the housing market issues in around 2006, 2008, it was the high deductible health plans was about anywhere from 4 to 8% were some of the stats that I saw. Today, 30%. Have a high deductible health plan. For instance, North Carolina, 70% of its private sector employees have a high deductible health plan. It's number one in the country right now. So we've got to start doing things differently. We've got to start addressing that patient and helping them through this process. In the past, when with a recession possibly looming, in the past, healthcare was protected because most of the revenue was coming in from insurance companies. So that kind of got healthcare through those times of crisis. But now, with more of it being due from the patient, we can't just continue to send the same collection notices and follow the processes that we were following when we used to, have the paper claims and we had to tear the pieces off the side of it. We haven't changed that much in how we collect from patients from that time. And we've really got to start looking at other approaches to engage and educate these patients. Starting in July, you cannot report a debt under $500 on someone's credit report. And you have to now wait a full year if you even want to credit report. So things and times have changed so much. So really having that consistent approach and helping that patient throughout that financial experience without disjointed processes is key.
All right. So we're going to have another poll. So this question is there an integration between your eligibility department and your self-pay and bad debt team? About 50-50. Oh, there we go. So 50-50 again. Okay, so it's about equal where yes, there is integration, and then no, there's not integration. So that's very common, especially if you use multiple vendors or you have different departments that you're working with and they don't understand what each department does or that handoff process. So that does make sense. All right, so we are going to go to the next slide. So this is discussing, fee and incentive structure. So this slide is a sample of a fee and incentive structure that we set up. It's really important to have service line agreements and KPIs to measure, regardless if you use a vendor or you handle it in-house. it's important to understand that current performance before you take action. So you can't really measure ROI or return on investment without understanding your current state. And so this highlights, for potential SLA to look at and providing the incentives or fees for, your team. So there's different areas here that you could really track. So looking at your resolution rate. So not just about that payment rate, but how quickly you resolve an account, whether it's a payment, an adjustment, and whether that adjustment comes from a financial assistance adjustment, whether it's a settlement, a payment plan. You're looking at anything to resolve and close that balance. And you have the call abandonment rate. So really to ensure that, you look at that abandonment rate and identify ways to help get access to that patient. So look at easier ways for patient for self-serving. You have the interactive voice using IVR, different ways to pay through online texting to pay. And then you want to be able to look at patient complaints. It's really important that you have a measurement to handle patient complaints. And so we have a team, a manager of patient advocacy that handles, our escalations, and that really does require delicate care, or patients who are upset or they're irate. This team, really helps to address that right away. The patients really need to feel like they have an outlet and somebody that they can speak to that can really hear them out, that can address their concerns and really ensure that there's resolution to their concerns. And then being able to look at that inbound and outbound calls and really hear cash, right? So cash is king, and it's really important to show those collections and improvement through, patient education for that greater collection. All right, so here to continue the cohesive strategy for patient balance, we look at measurements through different service areas here and being able to look at targets. And then you have holistic measurements you can create from these targets, right? So with Financial Clearance Center, want to be able to ensure you're clearing, 95% of scheduled encounters as that are cleared as a percentage of those scheduled encounters, and being able to secure 98% of those authorizations pre-service, pre-registration for those services, and then 50% estimates generated through the Financial Clearance Center. For the eligibility services, being able to have a 98% or greater for inpatient and high dollar outpatient accounts for screening, to ensure that you're screening those patients out for any and all programs. It's really beneficial to ensure that you have over a 70% plus in your gross conversion rate, and then also ensuring that you have less than 5% non-cooperations in closing. Then we look at that pre-service collection. So also being able to look at your point of service collections is key in terms of 1.75% as a percent of that net patient service revenue, and collecting 50% of the estimated liabilities for that service. And there's some self-pay and bad debt metrics. So self-pay is all about trying to collect from the patient. So it's really important to ensure you have a good quality monitoring, managing productivity, and good call stats. So being able to handle, over 70 calls a day, having a very high quality score is key. So here it shows 95. We actually are, I believe, at 96. Is that correct, Olivia, on our quality scoring?
It's because it's our gateway to incentive comp. And so that helps have high quality scores.
Yes, definitely. And that quality, it entails measuring the tone of the representatives and the colleagues, communication with that patient? Did they offer all assistance to that patient in terms of program opportunity? Offering all the options to resolve the account. Did they actually take the appropriate actions? A representative and a patient can have a great conversation, but it's really important that the representative has follow through. Handling escalations. Did they get the patient their receipt? So having those top scores will actually reduce that patient complaint percentage significantly. So, we have a less than 1% in our patient complaints. And then with the bad debt, making sure you have good call metrics with the answering the call, the speed to answer, your contact rate, we have 74%, and then having a very small wait time. And I'll hand it off to Olivia to talk through the benefits of having great metrics.
So the benefit, so patient-centric, of course, if you explain, if the patient understands why they owe, they're more likely to take action on that account to resolve. So our colleagues are trained what we call our BLAST approach, or our BLAST protocol, which is believe, listen, apologize, satisfy, and thank that patient. Thank that patient, offer them further assistance. Is there anything else that I can do today? Being empathetic, very empathetic is key here. Not only sometimes are these, bills, they're reminding patients of a healthcare, a scary time in their life, possibly, or a family member that was going through some very tough times with their illness. So really being empathetic, not being short, and really being understanding of why that patient may be upset or needs some additional care is key. They have to feel like you care. And it's something that is lacking. I don't know if anybody has noticed lately when they call anyone, it's short. And I'm like, thank you. And there's no, hey. And I'm like, it used to be, hello, thank you for calling Patient Financial Services. My name is Olivia. How may I help you today? Like, you have to have a script that you have to follow. You have to check those boxes to make that patient feel like you're engaged with them and that you're listening and you're taking in everything that they're saying. And with that quality being focused, the right action on that account, the right type of customer service. And then the last one in that strategy is really looking at how we can drive that resolution with those patients, looking at different factors, behavioral, but also where we look at our propensity to pay, how we segment those accounts. Where do we need additional hand-holding? Where do we have a lot of self-pay patients coming through the ER? Is there more education that we need to do there? Do we need to add a couple of financial counselors or someone to do point of service or screen patients there on the spot? What do we need to do to get those patients addressed so they don't continue to flow into bad debt? Because they'll never pay. And you have spent so much time lettering and calling someone that you should have engaged with at the very beginning. So what does our data tell us? What does the history tell us about these patient populations? And Amy and I are very excited about social determinants of health. And we're digging in here and looking at ways that we can address different pockets of our inventory and really help drive resolution of these accounts so they don't flow into bad debt.
Thank you, Olivia and Amy. That was a fantastic presentation, a lot of great information. Before we roll into the Q&A, I just wanted to let everyone know about an upcoming webinar that we will have on May 19th at 1 p.m. Eastern. The CDM, Leverage Its Power to Drive Revenue and Compliance, led by Kyle Sherseth, our VP of Revenue Cycle Solutions. I hope you can join us. With the time that we have left, let's jump into the Q&A. If your question has not been answered, don't worry, we will provide written answers to all questions following this webinar. Again, please enter your questions using the Q&A feature at the bottom of your screen. In the meantime, I did have some came through and wanted to get started. The first is, what best practices do you recommend to help hospitals successfully collect patient balances?
I can help answer this. So it's really important to have a data-driven approach to managing performance and really determining the right KPIs to track and measure. So knowing your patient population is important through data review, identifying those areas of need and having that strategy for collection. So being able to leverage, advanced segmentation, identifying your high and low patient touches to your high and low financial risk is really important. Being able to leverage technology to support services, so using propensity to pay. It's not just about the scoring, it's about the information that also is provided by the scoring. So understanding that household to debt, income and where they fit on the FPL, and utilizing, a screening tool to identify the right program for that patient. And also leveraging programs like presumptive Medicaid or presumptive charity really helps with that short-term relief while you have a team that focuses on the long-term resolution for that patient. And then using best practices in collections is key. So knowing how to use scripting, overcoming objections, really capitalizing on that patient interaction.
And I would add, another thing that we have got to start thinking about is right at front of the desk. So post-insurance related vocabulary, have it easy to read, and your financial policy. Make sure you're using automated eligibility and verification tools. You want to help the patient understand their coverage and track how close they are to meeting their deductible. If you have a lab that is attached to you, have a sign that says, this will be billed separately from your primary care visit today, or United Healthcare is, policy, this is not covered. Really having information out there and making it available so they understand and can ask questions is key. And then lastly, make sure the patient's bills are easy to read. Do not overcomplicate it with a ton of information. Make it clear and concise. Make it easy for them to make a payment. A lot have codes here and you have to go here and you have to sign up here. We should let anybody make a payment online that wants to. We will take a payment. Make it easy for them to do it and not a complex process.
Fantastic. The next question is, how can we leverage populations of patient data to improve the patient engagement journey inside and outside of their visits?
So that's a great question. So I would say that every geographical area is different, right? In terms of, the medium income, the type of work environments that are in the area, knowing, if it's really important to know your data, right? Do you get a high volume of recurring patients? Do you get a high volume of out-of-state or tourists? States also have different federal poverty guidelines. So really understanding those details are key and grouping the balances by those patient demographics through the data assessments. Identifying the right modality to contact the patient, right? Maybe they prefer, maybe you have better responses through letters or better responses through texting or emailing versus using a dialer. There's some states that don't, our contact rate for the dialer is very low. So we have to do a different modality to outreach to that population. So really understanding that to identify how you apply those different modalities for contact and processes is key through the data assessment. Patients are more likely to cooperate when they have something in it for them, right? And so identifying the right program is key. And some of these programs can actually help with monetary benefits for these patients. They can actually get cash. And so really identifying that, especially in your expanded states. I mean, expanded states for Medicaid, where the states are offering Medicaid to childless adults, a lot of times patients miss out on the opportunity for disability because they end up falling into a Magi related program. So being able to help that patient and letting them know, like, you really qualify for disability, where, and they can actually get a benefit, they're going to engage in more and provide more cooperation. And then just staying abreast of new developments, right, as they're occurring. So, we have the public health emergency, that recently was extended again, which allows for current Medicaid recipients to continue to receive their benefit without having to provide renewal or redetermination paperwork. But that is expected to end soon in July. And so with that being said, I mean, there's a large population of Medicaid recipients at risk for losing their benefit. So being able to perform a data assessment to identify, how do I proactively stay on top of this to ensure my patients continue their Medicaid so I don't see a high amount of self-pays in the near future?
That's fantastic. There is an interesting statement that just wanted to raise up. I thought it'd be really interesting to talk about is customer service reps need to speak English clearly, especially since some vendors use reps from other countries. And the reps need to speak slower since most people can't understand when people talk fast.
Yes, so I did see that. Thanks, Melissa. We talk about tone a lot. I do know some vendors do use global resources to handle some of those patient facing type activities. We currently don't do that. All of our call center team, all of our eligibility staff and our self-pay and bad debt staff are domestic team members, but we talk about tone. We talk about speed. Are we easy to understand? Did we have to repeat ourselves several times? So all of that is part of our quality score. But yes, patients can become easily frustrated if they're not understanding what you're saying. So I definitely understand and can appreciate the comment.
Fantastic. And we have one more question. In the front office, what strategies can be implemented to help boost revenue?
So with the front office, I would say, well, you think about, okay, so one of the trends in the market, right, is the rise in cost utilization. So doing more with less. And a lot of times you have high turnover when it comes to patient access staff. So I would say that, especially, I'm just thinking of front end staff may have a lot of different roles or hats that they wear, especially on site. So I would say that being able to have a team, that can augment your access staff that works remotely in a centralized fashion can really support a lot of that turnover and really help with those patients and talking to them to be able to give them that experience and that, that time. Being able to look at deferring those low touch patients through digital channels for communication. So, having self-service portal, a patient portal to communicate, having alternative methods for payment, so it's easy for that patient to be able to pay. And then being able to leverage a lot of the technology as it relates to, utilizing RPA for, screen scraping for eligibility, or utilizing eligibility, for insurance discovery. So you take a lot of that work off of the colleagues, so you can still get the results and still have your representative focus on that interaction with the patient. Estimation is really important. Propensity to pay, making sure you're getting the right estimate to the patient in terms of what their liability is. And really looking at enrollment qualification opportunity. There's a lot of programs out there. There's, we help with over, 18 plus programs for enrollment to really make sure you're looking at the right program for that patient that can help with their data service, is really important. And it may only help with one of their 5 dates of service, but it still helps to reduce that financial out of pocket for them. And then, of course, that point of service, having best practices in that collection opportunity.
And I would add also, there's just some simple things. Yes, you want to get the revenue in, but you also want to reduce your cost to collect. So go ahead and engaging and having that patient set up for e-communications, text reminders, going ahead and getting a credit card and having it on file. So when you do make contact, or they can press that button to make payment, really doing those things and reducing costs for letters and statements is huge for you. And you're immediately engaging with that patient. So doing those things, having reoccurring payment plans, drafts, not sending out monthly reminder notices, really reducing your paper and those type of things, looking at ways to, have patients where they would have to opt in to receive paper. So like, we've done it the other way. You have to opt in to receive electronic communications. You should have to opt in to receive paper at this point. We're going to communicate with you this way. Of course, there's going to be people that need paper and that are going to want to compare it and are going to still want to write a check. And we don't want to, not address those either. We want to help that patient however we can resolve the balance, but we have to start shifting how we engage and communicate with these patients, where it's a leaner, quick process.